for good bone, please. If this is a good bone, lot of length is available, definitely it will work. Whenever we are planning for bar, the only thing you have to make sure is you have got good prosthetic space. Because you need space for bar, then you need a minimum 3 to 5 mm is the dimension of the bar. So upon that we have to give the processes. So what we'll do is we'll do screw retained with this patient. This is an old patient. Just to revise the lower plan. Lower planning is the more easier than the maxillary plan. There is less number of variation. The sinus variation is anterior, downward, posterior, pterygoid, this kind of. But here only variation will be the nerve and the canal, distal atrophy.
So for the premental area, like without CBCT, we can do it. Resistant wala the purna aram se. Only thing is now molarity between.
You have to take IOP and see the canal and select short number of.
Adhu customer the open it.
Yes.
Easy.
Yes.
That will be on the safest track.
Yes.
Okay.
Whenever we are placing implant in the distal mandible, our first aim should be do not damage the nerve. So when you place implant, first thing, what is meaning by safety? It should not damage the nerve. It should not touch the metal foramen. It should not perforate lingually, bleeding on top. Okay. It should be safety. Okay. Then stability. At least decent. Minimum is 40 Newton. If you are placing 3 or 4 implants, if 2 implants are not stable, that doesn't matter. That is where the welding comes and helps us. Okay. Even if you are placing 6 implants, say 6 implants, even if 2 or 3 implants are less stable, 3 implants are good. Once you weld it, everything unites. It's called cumulative stability. Now they are coming with new concepts. They are adding each and every implant stability. They are adding it. So per arch, how much minimum Newton is needed for immediate loading? These kind of things. But if you use single piece with proper protocol, definitely will get 2 times so much higher than those minimum requirement. Safety, how will you achieve? By surgical anatomical knowledge, right? And during drilling, you have to feel the resistance, respecting the resistance. These 2 things will safety. Is these 2 is enough? No. So the abutment position should be in a decent position. If it is too buccal or if it is too lingual, we may have difficulty in processes. Right? The process may be bulky or the abutment may be very much lingual, giving aesthetics may be difficult to give. So abutment should be in a decent position. We have a lot of options to solve this problem. Bending, abutment preparation, but even then by implant placement itself, the abutment should come in here for 80% good stage, 10% you will correct it by bending, then 10% by abutment preparation. So first day after surgery, give marks to you. Safety, good. No risk. Stability, decent stability. Abutment, correct position. So first day, the success is over. But there is something called long-term success. It may be good now, but after 3 months, 6 months. So that is where process comes. If you place the implant, but you have not given any tooth, then no problem. Implants will osseointegrate. One patient, we did full mouth. Okay, implants. The next day, she was supposed to come for jaw lesion and all. The patient didn't come. After 6 months, she came. Then what she told, after implant placement, when I went in the road, she got in some accident. She got her bone got fractured, so she was bedridden for 6 months. Straight away, we went for a permanent process. Because everything is osseointegrated, no issues. But that is not the case. You are doing immediate loading. From the 3rd day or 4th day, patient is going to eat. Even if you are telling soft diet, they are going to eat. So processes becomes important for long-term success, and patient also evaluates success from the prosthetic viewpoint of view. They don't bother what is the diameter, whether you put pterygoid, cortical engagement, they don't bother. The tooth looks, aesthetics, speaking, mastication. These 3 things: aesthetics, mastication, speaking, and of course pain-free. So that is possible with the processes. Many of the failures will happen due to poor processes. So those aspects will cover today. Okay. So we always keep two mouth mirrors. One is for us, one is for the assistant to retract. Sometimes one mouth mirror may fall off, so backup. Okay. Then probe is essential. Sometimes we may have to remove the root tips or the suction tip is locked. We can use this. Okay. Then what is BP, blade and handle. So any surgery, even if it is mobile tooth extraction implant, or even if your healed area also, BP blade should be handy. For full mouth, you need to have two BP handy. Then a good periosteal elevator, always two. Okay, because sometimes one periosteal elevator may be blunt. At the time we cannot go down, so better have two periosteal elevators. And then Austin retractor. Mostly we are not using it because we are using after gate or dam. So Austin we are not using, but then curate, nice curate they are must. Okay. So we are getting from GDC. Don't get very big curates. If there is any big cyst and all, big curate is useful. But this is more than this curate, the tip will be serrated. Some companies they give the tip will be
Which is that one you are using, sir? Which is
this is GDC. GDC. Okay. And nice scissors to do gingivoplasty. I was seeing some all-on-4 surgeries in the online. They are using BP blade to cut the tissue, which is a bit difficult. If you have this double curved, here there is one curve, here there is one curve. If you have this double curved scissor, they are good. Okay. This is also from GDC, I guess. Okay. This is tooth forceps. Actually, this length is not correct. The length should come till here. So any intraoral instrument, it should come from tip to this part. Okay. So tooth forceps it uses during suturing you will be using, and during flap elevation also, to hold the flap and removing, elevating the flap is much easier. And then nice needle holder. Okay. The good needle holder what we found is from GDC. Okay. And curved artery forceps is must. Some brand of implants we need curved artery forceps to remove the implant, or any vessel bleeding, or any root tip removal, bone spicule removal. We need this. More than one also is needed sometimes. And scale is must for all surgeries. Okay. Make sure the scale is of correct dimension. One time the scale was not proper. Here there was 2 mm, 3 mm extra they manufactured. So make sure it is. And bone file. Actually it is difficult to find a good file actually. After extraction to smoothen it more, but it is not at all working. So it is for namesake we are keeping it, but it is not useful. So how to smoothen it? The best way is to use the burr, the round burr. Just few seconds that will lose job than this one. And of course the rhongus, elevators, periotomes. This extraction is the main segment. Yes, periotome. Periotome is not to elevate the tooth, that is to luxate it, to create some space in the
periosteal elevator.
elevator. It won't go into the periodontal ligament space. It will create some space, that's it. Sometimes it works. You cannot expect it to use to remove the tooth. Luxate has difference. Elevators are. So you can get this burr from any lab. I don't know. 3 maybe. For lab purpose burr.
It's like a cardboard burr only.
Yes. See, if you go to lab section in conference, they will have lots of kilo kanakla, they will have this. You can get to it. But if you ask the dealer for any special alveoloplasty burr, they will put a big bill. It will be the same burr. Don't ask for I want to do bone shaping. Just any
You
prostho
use this
lab.
also for prostho lab.
Yes.
Acrylic kuda
Yes, 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 yes.
That
Even
we can
pear-
use. The
even
acrylic
pear
use
shape-
பண்றது that
Yes,
pear
pear
shape
shape,
can be
yeah,
done.
that also you can use.
Okay.
Not necessarily round.
Okay.
Pear shaped burno, it is little more long, difficult to control.
Elongated.
It may touch the flap and all. That is why we are using. Previously we used the pear shaped only.
703.
But we can do in lower oral upper applying பண்ணலாம்ல full mouth-க்கு.
It's a good option actually. For us also, it will be less tiresome for the patient also. Because initially it may take even 1 hour, 2 hour also to finish one job. So, okay. Osseointegration is it doesn't happen in the first day. It takes 2 to 3 months. Biologically the cells come and unite something on it. Okay, this is osseointegration. So, osseointegration takes 2 to 3 months. That is why in the olden days they wait for certain amount of period. When the implant was initially practiced, they used to wait for 1 to 2 years, the brain mark time. Then slowly they reduced to 1 year. Then they slowly checked, whether if we give them. Then it comes to 6 months. Now, then after that 3 months, after 3 months they found in study that integration is complete by 3 months. So how it is possible we are giving in 3 to 4 days. Not necessarily in basal, even in conventional, immediate implantology is practiced now, all on 4, all on 6. Sometimes when the bone is soft, all on 4 people, they do after 3 months, or if they are initial stage, they are scared failure may happen for this patient, they take the decision for delayed loading. Otherwise, most of the conventional all on 4, all on 6 people, they also give fixed teeth in 7 days only. Okay. So how it is possible to give function, right? That is because of osseofixation. Okay. Imagine this is a strong wood. I am putting a nail and I am placing the calendar immediately. I am not waiting for 3 months to put the calendar. How? Because mechanically it goes and interlocks. Okay. So osseofixation means the implant goes and mechanically interlocks with the basal bone, which is a good quality bone. So it gets good stability and good locking. Mechanically it gets fixated, like similar to a screw in the wood. So immediately you can fix that. If you are not getting good second cortical engagement, if you are using short implants and if you do immediate loading, then failures may happen. Okay. So getting fixation from the nasal floor, some pterygoid, some good quality, D1 or D2, good quality bone, that is called osseofixation. What is the question is, if osseofixation works, then why the need for osseointegration? Okay, but the thing is, initially it works by osseofixation, whether it is conventional or after that osseointegration also comes into play. So it is a double dhamaka. Okay, so initially it works by osseofixation alone, but after 3 months it works osseofixation, osseointegration both. So that is why in the 3-month period the patient has to take care of soft diet, not chewing heavy food and all. So after 3 months they can start eating the hard food also. So first 3 months the teeth set is only for mainly aesthetic speaking only, not for mainly eating. So the patient has to take soft diet. If they miss that, then the problem may come. This is one implant, this is another implant. Okay. This is a polished implant. Okay. In the rough surface implant there will be threads, right? Yes. Okay. So here the surface area is, say for example, 1 centimeter. But here 1 centimeter, but this it gives 2 centimeter extra. And apart from that there will be a rough surfaces, microscopic, like this surface. So it gives 3 centimeter. So it gives 6 centimeter. Rough idea. So the surface area is more with the rough surface. Comparatively, the surface area is less. So there is something called BIC, bone implant contact. How much bone implant contact area? Here it will be less. Here it will be more. So comparatively, wherever possible, use the rough surface, whether it is conventional or compression design. Because long term you will get good BAC. So wherever needed, if you have seen, till now we have not used basal design. Only 5 to 10% maybe we might have used. Only when there is no label plate. So, Madam showed on X-ray, right?
Yes, sir.
So those kind of cases, they only basal will work. Conventional or compressive, they won't work because of there is no label plate till the apex. Okay. So there are some good indications for basal also. But the advantage with basal is they get support from the nasal cortical bone. Even though they are polished, they are fixing. No, osseofixation is good because the tip is, the thread is like this, but here the tip is like this. So the amount of bone engagement near the tip for compression implant will be less, but the amount of bone engagement for basal design will be more. Okay. So here, if it goes into the nasal floor, no, it will engage only less bone there, but if it goes, it will engage. Okay. So top to bottom there is good bone, no, I will use this. If there is very less bone or poor quality bone, osteoporotic bone, but good bone only here 2 mm. Even in cases of 2 mm, only 2 mm, this design will work. See, this is the.
So, waiting start my interest. Live port no?
Okay, this is the cross section of upper anterior. Yesterday we did know something like a palatal. See, the bone will be like this only also sometimes. The bone will be like this. Only nasal floor, not even slight bone, only 2 mm. This kind of bone also, it comes. I will show. What's up? This is a lower molar. Okay. If the canal is here, after extraction you can immediately place the implant. If the canal is here, this is not ideal case. So what I do is I extract, I wait for 3 months, let the bone heal fully, then you can place 2 short implants. Okay. So sometimes immediately after extraction the situation may not be favorable in partial cases or single tooth cases. Wait 3 months, then you can see the amount of bone present in the upper anterior area. Even in molar there is nothing. Even the pterygoid is not good. See the molar area, how much sinus is involved. See the bone here. Okay. It will be hardly 1 mm or 1.2 mm. There is no alveolar process, only nasal floor is there. That too. So no conventional implant can be placed. It's a classic quad zygoma case. Both sides 2 to the 4 zygoma. So here, but you can place a basal design because the tip has got only 2 or 3 teeth. They will engage. We got a 40-50 Newton stability here. Okay, but compressive cannot be used. Any conventional implant cannot be used. Nasal floor is only 1 mm. So this is the most severe cases. These kind of cases, basal, multi-unit, they work very nicely. So this is a 3.6 10 mm, little bit projecting into the nose anteriorly. In the buttress, this buttress small bone we placed, and somehow pterygoid we placed, and in the molar areas small
So
inserts.
one of the implant in the anteriors, which was more into the nasal thing, right? The cavity.
Yes.
How is it?
No, this is into the incisive canal.
Okay.
This is into the alpha part. Okay. If you see here, we give cantilever because there is very little bone. See, the mental foramen is crested. Okay. So what we did is we placed very small diameter implant, multiple implant, and we did a cantilever, double welding cantilever. Those kind of cases you can avoid molar and give only 2 premolar.
Over there, the molar is excluded. We don't place even the prosthetic molar.
Yes, this kind of very less bone cases, better to give only premolar to premolar.
Upper you will place it.
No, better to give premolar to premolar because upper is also not very big implants. To get support, we are going for
Even
pterygoid.
for placing that 6
Yes,
you
yes,
get support
yes.
from there,
Yes,
but replace only the.
Yes. In parliament they tell no, we are supporting from outside. So they are supporting from outside. We won't give any post to them. This kind of cases I like very much because the patient also no problem. Even the doctors also they won't ask any question of why this extraction and all. So it's very easy to tell the patient. But some borderline cases, sometimes patient may not accept why all tooth. Okay. So patient age is very minimal, only 38 or something around 38 only. So the ridge is very much resolved. Here and all, you cannot take this socket as guideline because they are very much tilted. So whenever you see this double chin, you should be very careful because oxygen may go down easily. They may have snoring issues. That is because of fat deposition. This double chin comes. That means inside throat also fat deposition will happen. So they will get oxygen. Since he may be overweight, even though it is edentulous, it is not reflected in the face because of thick. So classically you see thick moustache for this kind of patient. All teeth are gone, but these three teeth are still standing, white.
No pushing.
Yes, no lower teeth. The first teeth, this tooth might have fallen out, so they don't get any occlusal trauma. So they are standing nicely. Patient may ask, except this tooth, can you? As I remember, I want to keep my natural design.